It's Nicole, so we're ready to get started. Again, we've got Warner Thomas, our President and CEO for Ochsner Health, as well as Dr. Robert Hart, our Chief Medical Officer. And with that, I'm going to hand it over to Warner.
Good morning, everybody. It's Warner Thomas. We're happy to do this call. Hopefully we can answer your questions. Certainly you can send questions in as well. We do have a list that we're going to go through that kind of came from you, and we'll start going through those momentarily. I do want to start by kind of laying out kind of the situation, kind of where we are today. I think it's pretty widely known that we have a bed shortage, especially ICU beds, kind of around the region. Specifically in New Orleans, and I'll talk a little bit about that. There have been testing shortages, and there's only so many test kits, and that's getting better and ramping up, but that is a situation. There's a personal protective equipment shortage, generally because, the COVID patients or the patients that we think could be COVID patients require a significant amount of personal protective equipment for our workers in order to care for them. So it's multiples of what we would normally use. And that there's a nursing and a staff shortage. And I would say that before COVID-19, there was a nursing and a staff shortage, and probably one of the biggest challenges of Ochsner has been workforce in general, having enough people. So certainly this has, stressed that some. And I had some questions yesterday. Gee, we hear, the workers are stressed, and they absolutely are stressed. And I think we're all stressed going through this challenging time. But at the same time, I think we've got to put information out there that is helpful. We are communicating with our employees all the time, providing them, a mental health support phone line that they can call, employee assistance services. We open up an employee assistance fund for folks that maybe have a spouse or someone in their family that lost their job, providing some funding for them, providing free child care after the schools were closed. And we're redeploying people. Instead of laying people off in many of our other areas, we're redeploying them to help work in our hospitals or in our supply chains or in other areas of our organization. Today we see our clinics. We have many clinics, around the region, about 120 of them, that are down probably about 40%, 40 to 45%. So obviously we have some capacity with many of those staff members. We're redeploying them to work in other areas. So I just wanted to address that. The nursing shortage. Once again, I think we're redeploying people like medical assistants that are normally in our clinics to go to our inpatient floors to work as certified nurse assistants to support our RNs or LPNs in the hospital. And that's a typical model, but we are redeploying medical assistants out of our clinics that are not as busy. And Robert can talk more about redeploying some of our physicians, specifically surgeons who are working with our critical care docs to manage patients on ventilators and to work in a team. We've kind of set up teams of a lead ICU nurse with medical assistants or LPNs, a lead critical care doctor with a surgeon or other team members to really help us to broaden and extend our staff. So I just want to kind of get that as a background of kind of where we are today, and we'll start going through the questions that you got. Robert, do you have any comments on the surgeons working in the workforce and the team that we're trying to create there, just to give them more information?
Yeah, so we obviously know the ICU docs who, to be honest with you, we have some of them now with 2 weeks of experience taking care of these patients. And so as we add other staff, even when you think about some of our surgeons who take care of very sick patients, but that's not their job that they do all day long, but they certainly take care of their sick patients. And then anesthesiologists who are dealing with people on vents all the time. So they've all got certain skill sets that actually can apply when you put them in this setting. But then we make sure that we have the oversight of the ICU physicians, the critical care physicians, who, like I said earlier, have become very familiar with these type of patients, and they're able to give them guidance. And obviously, some surgeons are able to participate more in the medical care. Some people are able to be an extra set of hands, but everybody is working to take care of these patients. But again, the critical care physician is the guy running the ship and monitoring and working with the nurses and the staff to make it all work.
So one of the questions is, can you address the influx of patients beyond, kind of the regular capacity? Today we have, between confirmed positive and patients that are under investigation or kind of PUI, about 562 patients across our system. The confirmed positives are 271. And certainly we continue to see positives as we are, continue to increase our testing. Our contingency, we opened up 34 more ICU beds last Saturday, and we're ramping those up through this week with staffing. We're opening another, and that's our Jefferson Highway campus. We'll be opening another 62 ICU beds, getting the ventilators, getting the staff to be able to do that over the next week or so. We're essentially, and the question was, are we using other buildings or floors? We are. We're actually relocating several of our medical surgical floors for lower intensity patients that have been at Jefferson Highway to our orthopedic and specialty hospital on the Clearview Parkway area. We have 2 floors over there that were used previously for skilled nursing and other services that we are renovating, cleaning up, and we'll move our medical surgical patients there to allow us to have more critical care capacity at our Jefferson Highway campus. We're also adding 12 ICU beds to our Kenner campus over the next couple of weeks. So,
yeah, I think the only thing I'd add is it's always good to remember that as we've seen more and more of these patients, because we get the question about the surge and that sort of thing, and certainly we know that we have capacity constraints, but remember the other patients that we would normally be seeing have fallen down. So it's a different type of patient that's in our hospital, different mix of patient now in our hospital than what it used to be.
Yeah.
And the length of stay, and they stay a little bit longer because these can be fairly sick patients.
Yes, I would say it's safe to say we're seeing much higher percentage of ICU patients, a much higher percentage of people in our ICU that are on ventilators.
Right.
And our stay is longer with patients that are COVID patients in the ICU, probably 10 to 14 days, when normally we'd see patients on a shorter period of time in our ICUs.
Yes.
Thoughts about that, Robert?
Yeah, no, that's the case. These patients, they do stay a little bit longer. You take typically when we have more surgery patients in, post-operatively, they may be in for a few days or may be on a vent for a few days, and they come off and they recover and go home, and these patients are having to stay a little bit longer because of their medical issue.
Yeah. Another question is, how are we going to staff and equip them? Literally just got off the phone with the governor. He's helping us to provide some ventilators to us. We actually placed a large order of ventilators 2 or 3 weeks ago, trying to prepare for this. We've received some of those ventilators, so that'll help us staff it. We placed an order for 200 ICU beds, a few weeks ago. We're starting to get some of those in so we can redeploy them in our system. And staffing is probably the biggest issue, making sure that we can hire the staff. And so we are doing a couple of things. One, we've ramped up our own hiring around the region for nurses to come and join Ochsner. 2, we've actually reached out to national agency firms, and we will be bringing in some agency nurses to help us go through this, this period of time. This is pretty common and used pretty typically kind of throughout the country. So we're in that process, and we believe between those 2 steps that we'll be able to staff the beds that we anticipate opening over the next couple of weeks. one of the questions is we're seeking info on such things as how many COVID or suspected COVID cases in the system. I think I went through that. How many more patients are being admitted than usual? I would say actually our admissions are down. Obviously COVID admissions are up, but our admissions overall for our organization is down. Our ER visits are down. Our clinic visits, as I said, are down 40%. So, other pieces of the healthcare system have essentially kind of stopped or slowed significantly, and we've, redeployed a lot of those personnel and people to take care of COVID patients. So,
like you said, the total admissions are down, but you have to put this with really this lens of the acuity is up, the makeup, the mix of the patients is a lot more of these COVID patients, so they have a lot more medical issues. The acuity is higher, and then, like I said, even though the admissions are down, the hospital is getting more full, which goes back to the length of stay for these patients is longer than what our typical mix of patients is.
So one question, Robert, is I've heard talk about medical staff moving into dorms or hotels. Not clear to me whether that's happening yet.
We have not done any of that yet. No.
So there's a question here. So as cases rise, keenly interested on strategies to reduce the risk of this kind of transmission. So I guess what are we doing to continue to, drive the risk of transmission down?
Well, we obviously, it gets back to the PPE. We want to make sure that our staff has PPE to do the jobs that they're being asked to do. We're learning more and more about coronavirus every day or every week. But again, we want to make sure that staff has the PPE to do their jobs every day. And we have people, like you said initially, we have people working 24/7, really sourcing PPE from around the world to try to make sure keep our supplies up for everything.
Robert, there's a question about PPE. That there's anecdotal information or discussions amongst healthcare professionals about how to best reuse masks or other PPE, and just kind of our thinking around that.
Yeah. So again, knowing that there is a PPE shortage really around the world, not just in New Orleans or the U.S., we do have adequate supplies of everything right now. But what we have asked our employees to do is use it very conservatively, because it's a situation where we have orders coming in daily or weekly. It's not like we have a supply sitting somewhere for a year's worth of these things. And so we've asked our employees to be thoughtful about how they use it. And yes, we have asked employees to reuse gowns and masks, which in a perfect world, in a situation not like this, we wouldn't normally do. And so we have asked them that on the same patient, if they have a gown that they've used on this patient, to hang it up in the room, leave it in the room, don't bring it out in the open, but leave it in the room, and they can reuse it when they go back in the room again on that patient. But if it's soiled, torn up, that sort of thing, they need to get another gown. Masks, same kind of thing. We've asked them to reuse the masks, but at a point where it might get soiled or torn or not be effective, then we've asked them to get a new one. But and it's interesting. This I've made rounds on our staff, and they ask that question. Well, we have plenty, so why are we having to reuse it? And when you walk them through that, they understand, because we don't want to be like some of the other places I've heard where there are no gowns or there are no masks, that sort of thing. So we're trying to protect our employees by doing that.
Another question we got is, where are we searching for ventilators? Why is this so difficult? I think it's just, once again, I think about 80% of our patients that are going in our ICU right now, I believe, are going on ventilators. I mean, I think that was the percentage that we heard
Probably
yesterday.
about right, yeah.
So about 80% are going on ventilators. Normally, that percentage would be significantly lower.
Yeah, I mean, 30%?
Yeah. So you're up 2x plus the number of people going on ventilators in ICUs. So, you know, that is driving the need for more ventilators, and you know, they only produce a certain amount in the country. All of a sudden, there's been a doubling in the demand, and I think they're certainly ramping up the manufacturing and supply of ventilators. But because the demand came so quickly and from so many different areas across the country, I think we've outstripped some of the supply capabilities. So we're working with the state to get some ventilators out of the state. We're sourcing out of all of our typical suppliers that we use, and actually they've been very helpful and have been able to fulfill many of our needs. I mean, I would say, you know, it's something we work at every day, but we've been making good progress there.
Yeah. And I think to that point, you know, the issue is it's a problem across the country and the world. You know, we're used to dealing with, you know, we've had disasters that hit just one part of the country, and as you need supplies, you just get the supplies in because the rest of the country is running. In this case, there was a certain amount of ventilators being manufactured based on the usage that was normal, and that capacity is jumped.
Yeah, so more than double.
Yeah.
Another question, Robert, maybe you take this. There's a question about moving to separate some staff treating COVID-19 patients. So kind of, I guess, cohorting patients in certain areas. So maybe you can talk about how we're trying to handle that.
Yeah. So we have as you can imagine, as the volumes have ramped up in our hospitals, we now have certain floors where all of those patients are COVID patients, and so there's an expectation in those units that everyone there is a potential COVID patient, and so the idea is obviously that we don't want those same nurses up on a floor taking care of non-COVID patients. And that's just an infection principle. The other thing that we've done, Warner, is might mention in our emergency room at our Jefferson Highway campus, we have a triage system right at the entryway that really divides the patients if they have symptoms suggestive of respiratory infection, potential COVID, then they actually go to a different unit. So they never go back to the back where the rest of the patients might be. They actually go into a different unit, a unit that we were actually able to build, really take another unit and build it into a negative pressure area within about 48 hours, Warner, and process these patients through there. And so the nice thing is, it keeps our emergency department, for the biggest part, having to worry about every patient that might be a COVID patient, although obviously we're always on the lookout for it and concerned. But the majority of these are all going to one place, so it changes the workflow. All of those healthcare workers, everyone in there knows that this is where the potential COVID patients are, and so they're able to prepare for that a little differently.
Yeah. So we'll hit a couple more on PPE, then we'll go to testing. There's a lot of questions on testing. So, you know, there's questions about, are we running short on PPE, you know, personal protective equipment? I would say, you know, we are, I think we're fine right now as an organization. You know, we have created some different sourcing capabilities. We've worked with a couple of local breweries, distillers that are helping us make hand sanitizer. That actually, we started working on that about a week ago, and they're producing hand sanitizer for us, so that's kind of one of the innovative things we're doing. I think we're getting something like, I forgot the exact number of bottles. I think it was like 10,000 or 10,000, you know, bottles of about 10 to 12 ounces of hand sanitizer. So that's been a big deal. We actually were approached or got connected with Noah Couture, who kind of makes clothing and other items. They've now got the correct material to make the surgical gowns, protective gowns.
Yep.
And they've worked with our staff on the design, so they're starting to produce those now. We'll be getting thousands of those over the next couple of days. For the face shields, our Innovation Ochsner team basically worked to create a design of a face shield, and we're 3D printing the face shields. We have, hundreds of those that are being produced now, so people have their own personal, face shields. They're not disposable. You can essentially wipe them down with antibacterial lotion and continue to reuse them. So we're looking at other sources in New Orleans and in the region to produce some of these items, and that's helping us in addition to sourcing in our normal areas of sourcing, and we've reached out to many other connections across the country to identify masks and other personal protective equipment. So I think today we feel like we're in good shape. We are, being conservative in how we use the protective gear, but we're also, I think, holding our own and keeping up with the volume and demand from patients. So, Robert, I don't know if you have other thoughts on that.
No, I think it's great that the local people have stepped up, because in a sense some of their businesses have fallen, and this is a way for them to contribute and help out, and it's actually been good because some of our physicians, like you said, have been kind of helping lead the design and what works, what doesn't work, and helping to guide kind of the manufacturing of it.
Yeah. And I know there's a lot of questions about reuse of the mask and sterilizer reuse, and I guess Mayor Rob, you can give a little more color on this. I think if we feel like a mask is not reusable anymore, we ask our folks to discard it and take a new one. I mean, it's not like you're only given one mask and you have to use that all day. That's not the situation that we're in. So I think anytime we have a healthcare worker that feels like they don't have the right equipment, we want them to start and get something new. So I know, Robert, if you just want to hit the reuse thing.
Yeah, I mean, it's this is a different time. Like I said, in a normal circumstance, we don't reuse these things in these settings. But again, when dealing with patients that are COVID positive, then we think it's judicious to be able to reuse that gown for several entries into the room, as long as it's not soiled, as long as it can be used. But we don't want that gown, obviously, to come out of the room and go down the hall to a patient that, or a different floor that, where there's a non-COVID patient. So, again, it's not the norm, but this is a crisis kind of time period. And like I said, the conversations I've had with the nurses, they understand and they understand that we have the PPE, but we do have to use it conservatively to make sure it lasts.
Yeah. Okay, now let's go to testing. So Ochsner was the first organization in the state to bring testing in-house. We started that last Saturday. We are ramping up that testing capability. Previous to that, we were probably doing somewhere in the neighborhood of about 350 to 400 tests a day, many of those being sent out to the Mayo Clinic, who we work with in the laboratory reference lab area. Yesterday we did, Monday we did almost 600 tests. Yesterday we did almost 700 tests. And tests that we're actually taking. We're ramping up our ability to do this testing in-house. We think by the beginning of next week, we could probably be close to 1,000 per day. And that will include having a machine in Shreveport as well. Which will give us more capability. So that would put us probably closer to 1,400, 1,500 a day, kind of across the state. So those are kind of where we are. That turnaround time is same day. And Robert, maybe you can just hit briefly why same day is is so important versus a 7-day delay, or we're seeing 5 to 7 day delays when we send these tests out.
Right. So you have all y'all have all heard the 5, 7, 8 day returns on these, and we had those same problems initially, and that's why we really worked to bring that in-house, and some of our vendors were really good about working with us and getting us going with in-house testing. And I would say our pathology group really stepped up and did some incredible work to get that up and running. So the great thing about the turnaround time is two things. One, there's a peace of mind of just getting that result sooner. Two, the message to a person, a patient, when they know whether their result is positive or negative, and about the guidance to self-quarantine, has a lot more meaning if they actually have a positive test. It's just, the psychology behind that has a lot more clout when you know you have a positive test and you're told to quarantine or self-quarantine. The other big thing is, and this gets back to y'all's questions about the PPE, one of our big problems with our patients is we have all these patients in our house, in our hospital, who are under investigation, so we're pending results. So when we were waiting 5, 7 days for these to come back, our nurses are having to spend a lot of time putting on the PPE, going in and out of the room. We're blowing through PPE. I mean, we may have nurses spending several hours of their work just putting on and off PPE. If we can turn this around, as we've been able to turn these around in 24 hours, all of a sudden we're not having to blow through the PPE. We're saving the nursing time so that they're actually able to concentrate on all the care things instead of just coming out of the room. The other thing for our employees is it gives them a faster turnaround to know when they can come back to work, and gives them peace of mind also with their families about the self-quarantine issues, that sort of thing. So the 24-hour turnaround, Warner, is just a huge thing to be able to do.
And we're getting, one of the questions here is, once again, this is available. We're going to have another machine later this week, which ramps us to 1,000. A fourth machine that'll be in Shreveport ramps us to 1,400. So that'll be in place over the next week, we believe.
And we're also looking at some other new technologies that may be out.
So there is a question about that. That's okay. So there's a question about the technology. Let's see. That has the essentially the shorter turnaround.
Mm-hmm.
Just getting the exact question here from one of the reporters. I'll find it. Oh, here it is. FDA recently approved tests that show results in roughly 45 minutes. Can you tell us if Ochsner has requested these faster tests? Will we receive them? Kind of where are we with that? It's probably more point-of-care testing.
Yes, yeah. Yes, we are working with our vendors to get that in. We have put in requests to get those. We have our pathologists, reviewing that whole technology, the testing, the results, sensitivity, specificity, that sort of thing. The good news is we actually have the machines to be able to run some of those tests. It's just a matter about getting those particular test kits in, and we have put in for those. Yep.
And if we're not hitting your question, please send it in on the WebEx. We got a couple more here we're going to hit. So some questions about how does this current situation compare to the demand and strain that your hospital felt in the aftermath of Hurricane Katrina? What modeling are you using to predict the surge? So I guess a couple things. And I was here during Hurricane Katrina. Very, very different situation, quite frankly. Ochsner is a very different organization today. Then we had essentially one hospital in New Orleans. Today we have 5 hospitals in New Orleans, so it's a little different situation. We've been able to manage moving patients around to our various facilities. They're all on one electronic medical record. Yesterday, we moved patients from their West Bank facility to the North Shore to Slidell Memorial. Because they had capacity at Slidell, we had challenges on the West Bank, and all of the clinical information can go with that patient. So we are definitely looking at how we move our patients, or if we need to move patients, how we can do that in our system. I think that comparison to Katrina is a little different, that we were one of only a couple hospitals open during Katrina. Now everyone's open. I think that the challenge on the disruption and, trying to get materials and whatnot, I see some similarities there. But I would say that the Louisiana state government has done a great job working with us to help us. They've done a great job communicating with us and providing us support. So I think that's a big difference today versus Hurricane Katrina. And, we did not have to, in Katrina, we sheltered most of our workers in place, at our facilities, and they couldn't go home because they really, the city was not in a situation where you could go home. That isn't the situation today, so these folks can leave and go home, back to their, situation at home, their family, and come back. They have some semblance of normal life outside of work, whereas Katrina, there was no semblance of normal life. It was really 24/7 you were at the facility. During Katrina, we had a team A and a team B, so you'd work a week on, and then you'd get a week, off and kind of, go and have relief. So it's a very different situation compared to Hurricane Katrina. And I do think the duration, there'll be duration for a period of time, which will probably be very similar to Katrina. And, we anticipate we'll be having COVID patients through the remainder of the year, just at significantly lower levels than kind of where we are today, and certainly testing will help that. We've been questioned about, what are we doing to model patients and model the surge. Our public health research scientists internally have built a model working with some of the data from the University of Pennsylvania, and we actually have a pretty solid model for Ochsner and now for New Orleans of how we are looking at the projection of ICU and ventilator needs over the next couple of weeks. So a lot of this depends on, is the social distancing working, and do we move from an infection rate of one person who has COVID infecting 3 people to, one person infecting 2 people or less? And, that's going to be the question in the model, is the social, distancing working? We believe we've seen some impact of that, but with that being said, we have to keep doing the things we've been doing, being careful so we don't spread, and allow us to move through this peak carefully over the next couple of weeks. But we've built a pretty good model internally that we're working to project that information. Are there enough test kits to cover the number of cases we need to do?
That's hard to say. We always looking for more test kits because the volume right now is huge. And obviously, as we get more test kits, we will continue to test more people, which will help guide us and our direction to them about the self-quarantining and that sort of thing, and then all the other benefits for our inpatient patients as well. Yeah.
There was a question about what about our staff and what's happening with them? Do we have folks that have tested positive for COVID that are in our organization? And the answer to that is yes. Let's see. I've got it here somewhere. Oh. I believe yesterday it was about, I think we had about 60 people who were in our organization that tested positive. Once again, you got to remember, this is out of thousands and thousands of people that are employed in our organization. We had approximately 300 people who were quarantined for safety reasons that we had worked through. So that's really what situation that we had yesterday. There's a question about the drugs that we're using and whatnot. So Robert, I'll let Robert take this question.
Yeah, we've been using there was a question about hydroxychloroquine, and yes, we have been trying that to see what kind of effect. To be honest with you, I don't know. It is early in the sense that I don't think we have great data to show that it's made huge benefits, but there have been reports where it's been effective. We do have people on clinical trials with remdesivir, so we are in a position where we can put patients on clinical trials using that if our physicians think that it's appropriate. So yes.
Yes. And a couple other questions that we got here. And just on the 300 that are quarantined and the 60 positive, that's across our entire system. So that'd be New Orleans, North Shore, Baton Rouge, Bayou regions. That kind of cover the whole, southern Louisiana area. I think there's questions about questions about, for field frontline doctors, nurses, assistants, how has work change increased because of the growing number of cases? I mean, as Robert indicated before, just, continuing to use the personal protective gear all the time, whether a patient's presumed positive or not. So we've, I think that's been harder on the staff, quite frankly, and on our teams, and they've tried to work through that. And we'll, I think the testing internally, as Robert indicated earlier, getting same-day turnaround testing is going to help us sort that out in pretty significant detail. Got a question about our numbers for our Hancock facility in Mississippi. I don't have those numbers specifically right here. We can get those to you. We're happy to talk to you. How are we prepared in Mississippi? The same way we're prepared in New Orleans and on the North Shore. We've used all the same systems, all the same resources across our system. So we've hit most of the questions. A lot of them are duplicative. If there's a specific question, we'll open the line. If there's additional questions, we're going to open the line now to see if anybody has any other questions. So.
This is Jessica Williams over at The Advocate. I just wanted to get clarity on the difference between the ventilator.
That looks fantastic. Actually, very good.
ICU bed to run the ventilator, or the things exclusive?
Can you? So if somebody else is speaking, if you can put your phone on mute, if you're not speaking, that'd be great. Can you just hit that question one more time, please?
Sure. I was trying to understand if you need an ICU bed to run the ventilator, or if you could, because I know there's a shortage of ICU beds, and it sounds like a shortage of ventilators. Do those two things work together, or can you have a ventilator in a regular room without an ICU bed?
No, the ventilators, we use the ventilators in the ICU bed. So just to clarify, we have ICU beds that may not have a ventilator.
Hey, how are you, man?
I'm doing good. Where are you? Are you home in your office?
Can you go in the office?
I got you.
Yes.
And in the office in the lakefront arena?
Hey, whoever's on the lakefront arena, can you go on mute?
Okay.
Yeah, that's what my office is, actually.
Okay.
Hey, I need you to put your phone on mute.
Me, I can see you.
I can see you perfectly. Can you hear me well, Tim?
I'm sorry, I cannot see you.
You cannot see me.
You will not see us. We do not have a camera hooked up to the computer.
All right. You will not see us, I'm told. So look straight ahead at the camera, just like you are now. Look straight ahead at the camera, and I can see you, trust me. And if we have a problem, we'll stop down and start over.
Okay? Out at the lakefront, we can hear your entire conversation.
Okay, here we go. We're counting it down in 5, 4, 3, 2, 1. Tim, these are unprecedented times. As the leader of the athletic department at the University of New Orleans, what are you telling your coaches?
Okay, we're going to respond to your question question about the
Yeah, so
ICU
basically
ventilators.
just text your message in or send it on the WebEx, we'll answer it. So on the ventilator, you really use ventilators in the ICU. You don't really use ventilators in a typical medical surgical bed.
Right.
So yes, I mean, ventilators and ICUs go together. But typically, as Robert was indicating before, normally about 30% of patients we see on ventilators, roughly.
Right. Depending on the mix of patients, it might be 30% to 40%, but now a lot of these patients, 80%, are needing ventilation at some point, needing to be on a ventilator. So,
other questions we can answer for you?
And I know there's going to be a vote on March 30th about adding an extra year of eligibility to those athletes in spring sports.
From the WebEx,
For a school like the university.
Send me your messages via the WebEx right now. We can take them for a few more minutes.
Any other questions we can answer for you? We'll get to the specifics on the cases in Mississippi. I don't have that kind of at my fingertips right now. I guess please give our PR team feedback on whether these are helpful or not. If they are, we'll be happy to continue to do them. If they're not, then we're happy to stop as well. I think we do have one more question here that's coming in. Just tell me the question.
Confirm the number of the suspected and confirmed patients again that we went over.
Yeah. So we have in-house across our system 562 patients that are in-house across our system that are either confirmed positive or presumed, or patient under investigation. 271 of those people are confirmed positive that are in our facility. Anything else?
Ventilators. If we have any more information on ventilators, any numbers we have, like how many we have,
yeah,
projecting how many we think we're going to need.
So we have 207 ventilators in use today. We have about another 100 that we could put, that are ready to go into use should we need them right now. We anticipate another 100 for the future expansion that I said we're going to open up the ICU beds. So that's kind of where we are today in ventilators. So we think we're in a good shape from a ventilator perspective right now, but once again, as more patients go into the ICU and need ventilator usage, we're going to watch that carefully, but that's the current ventilator usage. How much do ventilators cost? I don't know, but I know how much 100 costs. We'll get you a number. I think it's something around, I think it's about 50,000 each, but I'll get the exact number and let you know. So. Any other questions? So once again, as we're wrapping up, thanks for joining us. If this is helpful, let our PR people know. If not, please let our PR people know. And we appreciate trying to be provider of information and try to be as transparent as we can as we go through this time. And I would just please ask you to keep indicating in your articles that you do the importance of social distancing, the importance of adhering to these protocols, because they absolutely are helping us reduce some of the spread. And I would just encourage you to keep putting that in your messaging. So thanks a lot and have a great day.